In this, our second module, we will delve deeper into the history of quality as it relates specifically to the EMS profession. Once completed with this module, you should be able to identify historical figures who have contributed to modern quality improvement initiatives, identify government structures that support and facilitate quality in EMS, create and identify the components of a key indicator, defend the use of or share quality improvement initiatives with private industry or trade groups, and locate and review 5 major trade or government projects fostering quality improvement in EMS. The scenario to kick off the discussion for this module involves a service that has had problems with restocking EMS equipment. On one call in particular, a sick child needed fluids and the crew wanted to initiate an IO line. Unfortunately, the crew did not know their IO needle was missing until they needed it on this call. Luckily, the second arriving unit had an appropriate IO needle and the intervention was able to be performed without too much of a delay. Upon investigation, it was determined that the same crew used the only IO needle in the medical kit the week before and never restocked the kit with another needle. A subsequent crew recognized that the needle was missing, but there was not another needle available in the station's restocking inventory. They filed a request for another IO needle through the proper channels, but the person responsible for filling such orders was on vacation at the time. To complicate matters, the IO needle was expensive and could only be obtained through an exclusive vendor as a special order item. Ultimately, the department's supply chain was determined to lack the speed necessary to support a just-in-time replenishment system for this particular item. To address this supply chain issue, the department identified 3 individuals who were willing to take some responsibility for addressing inventory problems. Not only did these individuals have some occupational background in logistics and supply chain management, but having more than one person also provided a certain amount of redundancy and backup in the proposed update to the system. Within a month of empowering this small committee to fix the problem, each station had standardized vehicle and station inventories along with a new standard operating procedure addressing EMS inventory management. Minimum and maximum numbers were established for each inventory item, and a computerized inventory system was employed to email supply requests to a redundant chain of command. Mission-critical inventory items were also identified to be maintained within EMS supervisor vehicles and the battalion chief's office. Are there any lessons that can be learned from this scenario? More specifically, what do fire departments and EMS agencies have to learn from other organizations' quality initiatives? Is it necessary to have to learn your lessons the hard way, or is there value in working with other agencies to share experiences and avoid similar problems? Within your own service, do you know if any of your existing staff have quality experience through formal education or experience at other employers? Why would it be important to know that? If you have people like that within your organization, do you think their knowledge and experience would be valuable? From a broader perspective, what is the history of quality initiatives in your organization? What about quality within your local government or fire and EMS agencies in general within your region? Do you think quality is an issue within these different realms? Are there some who do a better job of focusing on quality than others? How do successful EMS agencies ensure quality? As mentioned previously in the first chapter of the text, there is an increasing focus on healthcare quality within the United States. While there are many systems out there for ensuring quality, the common denominator in all of them is to ensure you are meeting the needs of those who pay for and use your product or services. Quality systems and initiatives, when properly employed, often reduce costs while also improving the customer experience. Within this text, the author focuses on 3 specific individuals who are very influential in developing and promoting quality management principles and systems. Walter Schuhart focused on variation. W. Edwards Deming provided us with a system of profound knowledge, and Joseph Juran introduced us to the quality trilogy. Do not worry if you have no idea what all this means yet. We will be exploring these facets of quality management within the remainder of this module. The origins of modern-day quality management go all the way back to the Industrial Revolution. As business and industry of the time grew and competition favored those with a competitive edge, it proved advantageous to improve quality in the production of manufactured goods by minimizing waste, including those caused by human error, streamlining processes, improving supply chains, and increasing precision. In those early days of quality management, scientific management, as it is called, focused almost exclusively on productivity of the workforce. Over time, it became apparent, however, that quality cannot be defined solely by productivity, as higher rates of productivity proved to not be sustainable over the long run. The lack of creativity and commitment on the part of employees was the downfall of using scientific management principles on their own. The need to recognize humanistic or behavioral science principles in the quality equation evolved, leading to the system of quality management routinely employed today, quantitative approach. Within this approach, information models, computer simulation, optimization models, and statistical principles are all used to foster and drive quality. In today's global business climate, quality management and continuous improvement are not just luxuries, they are necessities for businesses to remain relevant and competitive. Quality has become such an important concept within business and industry that there is an organization called the American Society for Quality. Its first honorary member was Walter Schuhart, an engineer recognized for introducing the concept of variation into the production process. Essentially, variation was a deviation in the produced good from its design. As an example, imagine a process that produces widgets. The widgets are designed to have a diameter of 4 inches. The variance in that production would be any widgets that have a diameter larger or smaller than the designed 4 inches. Depending on the purpose of the widgets, maybe some type of variation is okay, and a widget of 4.5 inches would be tolerable. In many applications, however, significant variation is not acceptable, and a widget produced outside of design specifications must be discarded at the expense of time and money. Schuhart was one of the first pioneers in combining engineering, statistics, and economics to develop what is known today as quality control. Schuhart looked at variations in production and identified 2 different types that we will discuss here. The first type, known as common cause variation, may be time-consuming, costly, and wasteful, but not to the point that management is too concerned. After all, even the best processes typically have a certain amount of waste that is acceptable. The second type of variation was special cause variation. This type of variation resulted in a deviation from the planned process that necessitated management investigation to ensure quality and maximize productivity. These are deviations that management could simply not afford to ignore. Schuhart is recognized as being the first person to develop a statistical tool called a control chart to distinguish between common cause and special cause variations. These charts were designed to help monitor process variation over time, thus providing the means to identify common cause and special cause variation. Schuhart also developed what has become a standard process for change management and action research, the PDCA cycle: plan, do, check, and act. This cycle begins with planning, followed by implementing that plan, checking the results to see how the plan worked, and then acting based upon that information. Maybe the plan itself worked fabulously, or more likely, some additional interventions were identified to continue pursuing process improvement, at which point the PDCA loop starts over. It is an iterative process that feeds upon itself with the goal of continuous improvement. W. Edwards Deming was a colleague of Schuhart and pioneered the thinking that production problems resulted from flaws in the system itself, not from the workforce. As part of his work, he further refined Schuhart's PDCA cycle into the PDSA cycle: plan, do, study, and act. With a combination of the PDSA cycle, statistical process controls, and operational definitions, Deming worked to improve quality in a manner that is still used today. Many attribute Deming's work in quality with the Japanese reputation for innovative and high-quality products, as they really embraced his quality philosophy after World War II. In today's world of research-based medicine, the PDSA cycle is still employed along with statistical analysis to seek quality improvement in healthcare. Another recognized grandfather of quality management is Joseph Juran. Juran believed that quality improvement programs must reflect the strong interdependency that exists among all of the operations of an organization's production process. Pieces of a production puzzle do not exist in a vacuum, separate from each other. Rather, every facet of production has an impact on other areas. Thus, quality initiatives must envelop the entirety of the process, not just individual pieces. Given his work in the field, Juran established 3 concepts key to eliminating deficiencies in an organization's production process: Known as the Juran trilogy, these three concepts include quality planning, quality control, and quality improvement. In quality planning, the organization seeks to understand what the customer needs and designs all aspects of a system that is able to meet those needs reliably. Once the system is operating, quality control is used to monitor performance with the original design or performance standards. If deviation is discovered, the identified problem must be corrected immediately. Lastly, even a well-functioning system can achieve further efficiencies. Quality improvement occurs when new, previously unattained levels of performance are achieved. Juran also recognized that businesses do not have unlimited resources. It is important to prioritize quality improvement initiatives to generate the greatest impact on improving the ability to meet customer needs. Needless to say, while Schuhart, Deming, and Juran are recognized as pioneers in the field of quality management, there are other contributors to the field who are worthy of noting. Phil Crosby was a hospital corpsman for the U.S. Navy and a private industry quality engineer. His most important observation regarding quality was that there was a significant cost to an organization that lacked quality. The costs associated with rework and potential litigation were more than those associated with doing the job right the first time. Crosby believed that the actions of management were reflective of their commitment or lack thereof to quality. Training all employees on quality is important, and it should be everyone's goal to achieve zero defects in production. Kaoru Ishikawa was a Japanese colleague of Deming who believed that quality could always go one step further. As part of his efforts, Ishikawa created the cause and effect diagram, often called a fishbone or Ishikawa diagram, to help discover the potential causes of a result with the goal of identifying the root cause of any quality issue. Ishikawa used several tools, such as histograms, statistical charts, and others, to assist in his pursuit of quality, and believed that quality must be a focus for the entire lifespan of a product or service. Another one of Crosby's contributions to quality included his 4 absolutes of quality management. 1. Quality means conformance to requirements, not goodness. 2. Quality is achieved by prevention, not appraisal. 3. Quality has a performance standard of 0 defects, not acceptable quality levels. 4. Quality is measured by the price of non-conformance, not indexes. As we discuss quality further in this course, these absolutes will appear with regularity. Today, there are a couple systems for quality management that are considered industry standards. The first is Six Sigma, which is a measurement-based strategy for process improvement and problem reduction completed through the application of improvement projects. The underlying premise of Six Sigma is to increase performance while decreasing variations in production. This ultimately increases employee morale and the quality of the product or service while reducing defects in production. Another quality management system used within business and industry is Lean. The Lean process is summarized in 5 core principles. 1. Specify the value desired by the customer. 2. Identify the steps in the value stream for each product or service, eliminating whatever steps do not necessarily create value or quality. 3. Make the product or service flow smoothly through the remaining value-added systems. 4. As the flow of the process is introduced, allow the customer to pull between all steps where continuous flow is possible in the process. 5. Manage toward perfection so that the number of steps and the amount of time and information needed to serve the customer continuously falls. From a practical standpoint, one of the keys in the Lean process is to identify steps in the process that do not add value. Streamline the process where possible, which helps reduce errors and improve overall quality. Those familiar with manufacturing already know about ISO 9000. The International Organization for Standardization, ISO, published specifications for a standardized system of quality years ago, and numerous countries have adopted the ISO 9000 series as a national standard. Within the United States, the American National Standards Institute, ANSI, serves as a member body to the ISO representing the United States. The ISO 9000 series standards provide direction for suppliers of all types of products who want to put into practice or improve effective quality systems within their organization. These standards are already used by companies that produce equipment for EMS, and they can be applied by EMS agencies as well in the delivery of EMS services. The goal is to build quality into every aspect of an enterprise with an integrated quality management system. By employing a quality assurance system, organizations strive to prevent problems from occurring, detect them when they do occur, identify causes, fix the issues, and prevent a reoccurrence of the problem. This should be the goal of any EMS-related quality improvement initiative as well, especially considering the very real life-altering problems that could occur if an EMS system lacks quality. Despite the adoption of various quality management systems within private business and industry, EMS has not historically pursued quality as an ideal. Rather, the push for quality in EMS has been driven largely by physicians familiar with or associated with EMS. These physicians have worked to improve EMS through several professional organizations, such as the National Association of EMS Physicians, the American College of Emergency Physicians, and the Society for Academic Emergency Medicine. These organizations have numerous committees and work groups dedicated to quality in EMS. Ultimately, these groups have proven indispensable in moving EMS toward a culture of quality and were the first to publish textbooks regarding quality in EMS. Through these organizations, medical directors have the opportunity to attend courses related to the promotion of quality management in clinical operations. Other organizational activities devoted to improving research and education in EMS also have the cursory benefit of driving quality within EMS. Given the importance of emergency medicine as a vehicle for reducing death and disability within the population, the United States government has moved forward in encouraging quality within EMS, beginning with the National Highway Safety Act of 1966. Other initiatives and laws, such as the Malcolm Baldrige National Quality Award and the Patient Protection and Affordable Care Act of 2010, with its focus on quality medicine and patient outcomes, further bolstered the need for EMS agencies to foster a culture of quality. The need for quality as recognized by the government does not stop there either. Back in 1973, the Emergency Medical Services System Act, which updated the Public Health Service Act, established minimum requirements for EMS systems based upon the components of the system. More recently, in 1996, the U.S. Department of Transportation and the National Highway Traffic Safety Division published the EMS Agenda for the Future, which narrowed the focus of the national EMS activities from the 15 components denoted in the EMS Systems Act to 14 attributes that more fully integrate into the healthcare system as part of community-based EMS systems. As EMS systems are modified, the focus on quality will be measured in a research phase at the beginning, in an evaluation phase at the end, and the overall quality of the system is measured by the impact it has on the movement of the patient through the healthcare system. To support such quality initiatives, data is required. Within a single organization, localized data is probably more than adequate for the majority of quality improvement activities. Looking at a larger system across a broad geographical area, however, requires a compilation of data across numerous agencies that sometimes exist across jurisdictional boundaries and state lines. One such tool for the collection of such data is the National EMS Information System, NEMSIS, co-sponsored by NHTSA and the Health Resources and Services Administration. The purpose of NEMSIS is to evaluate patient and EMS system outcomes, facilitate research, and develop nationwide EMS training curricula. Within Wisconsin, all transporting EMS agencies are required to submit run data to the Wisconsin Ambulance Run Data System, WARDS, within 7 days of the patient transport by Administrative Rule DHS 110.34, Sub 8 and 9. This information is not only used by DHS for numerous system improvement activities and public health monitoring, but it is also uploaded into the NEMSIS database as well. To support such data collection activities on a broader scale, the National EMS for Children Data Analysis Resource Center provides a technical resource for EMSC grantees and state EMS offices to assist in developing organizational capabilities to collect, analyze, and utilize EMS and other healthcare data with the goal of improving the quality of care provided by state EMS and trauma systems. The NEDARC assists EMS offices in establishing research designs, determining what data to collect, selecting a collection tool, storing the data, overcoming barriers to collection, coordinating data from other systems or agencies, converting data to a standard dictionary, formatting data to conform to a data model, and cleaning or standardizing before aggregating the data. Another important agency at the federal level for healthcare quality is the Agency for Healthcare Research and Quality. Established in 1989, this federal agency is responsible for improving the quality, safety, efficiency, and effectiveness of healthcare for all Americans. Their goal is to promote measurable improvements in the quality of healthcare in America, gauged in terms of improved quality of life and patient outcomes, lives saved, and value gained for what is spent in the healthcare system. There are non-governmental agencies that also work tirelessly to improve healthcare outcomes for patients. One such entity is the Institute of Medicine. The IOM strives to provide unbiased and authoritative advice to decision makers and the public related to quality within the healthcare system. Along those lines, the IOM defines quality within healthcare as the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. Even Medicare will begin to have a profound impact on quality in EMS by virtue of proposed changes from a pay-for-service model to one that pays based upon performance and quality. More than a decade ago, in 2005, the Medicare Payment Advisory Commission recommended to Congress that Medicare adopt a pay-for-performance model to foster quality within the country's healthcare system. Rather than basing Medicare reimbursement upon the number of procedures and interventions performed, which leads to overdiagnosis and treatment in pursuit of reimbursement dollars as opposed to what would be best for the patient, a pay-for-performance model would look at patient outcomes and the holistic care provided to the patient based upon quality-enhancing activities that are supported by information technology. This push has been incorporated into subsequent healthcare legislation, and even though EMS was not specifically considered within those legal provisions, the impact will apply nonetheless. One last government program with an impact on healthcare quality is the Malcolm Baldrige Award. Managed by the U.S. Department of Commerce's National Institute of Standards and Technology, this award acknowledges organizations that demonstrate the highest standards of performance in medical quality. To earn this award, a healthcare organization must excel in 7 key action areas or categories: leadership, information and analysis, strategic quality planning, human resource development and management, EMS process management, EMS system results, and satisfaction of patients and other stakeholders. Outside of governmental influence, there are numerous trade groups and organizations that also impact quality within EMS. 2 such organizations are the International Association of Firefighters and the International Association of Fire Chiefs. While these 2 organizations are not always considered allies, they do fund a joint study to define quality indicators for agencies that provide EMS services. The IAFC also produced a document that includes the basics of quality improvement through its Volunteer and Combination Officers section. The National Fire Protection Association has developed the NFPA 450 Guide for Emergency Medical Services and Systems, which addresses quality management, clinical quality, and data reliability, among other system elements. The National Association of EMS Officials, formerly the National Association of State EMS Directors, has been a leader in creating a common set of performance measures and partnered in 2002 with the National Association of EMS Physicians to develop 35 consensus-based performance measures for EMS systems. There is also the National EMS Management Association, which is a supporting agency to the National EMS Performance Measures Project. Members of the organization benefit by having access to comparative information and shared best practices in system quality. While typically associated with hospitals as opposed to EMS, the Joint Commission, formerly the Joint Commission on Accreditation of Healthcare Organizations, is recognized as the national leader in setting standards for healthcare organizations. The Joint Commission is rooted in performance measurement, and being accredited by the Joint Commission demonstrates a commitment to providing safe, high-quality healthcare with an impetus on continuous quality improvement. The impact of the Joint Commission on EMS at this point has been somewhat of a trickle-down from the physician medical director, who is typically accustomed to Joint Commission standards given employment with a healthcare organization such as a hospital, to his or her EMS agency. In time, it is suspected that the Joint Commission may have a more direct influence on EMS agencies. To assist in evaluating Joint Commission requirements, a quick introduction to some key terms is worthwhile. A Joint Commission standard is a generalized goal that is an achievable model of excellence. An indicator is an objective behavior or outcome that can be measured to determine compliance with a standard, and a threshold is an established level or percentage of acceptable compliance that indicates when further evaluation should be initiated. To put this into EMS parlance, a standard could be the requirement to provide high-quality compressions during resuscitation attempts. The related indicator would be data received from devices, such as one that measures the depth and rate of compressions. The threshold would be that high-quality compressions should be delivered a minimum of 90% of the time. The last trade group to be discussed in this module is the Institute for Healthcare Improvement. Founded in 1991, the IHI has been involved in EMS quality initiatives and projects in several countries. It provides education, best practices, and support to agencies looking to enhance their quality improvement activities. As already discussed, EMS agencies typically lack the subject matter expertise internally to develop and run effective quality improvement programs. There are very few educational opportunities related to quality management in EMS, and consultants are routinely utilized to assist EMS agencies in developing and maintaining their quality improvement initiatives. Over time, the hope is that emerging training and education, such as that provided by this very course, will fill that knowledge gap. Until EMS agencies are able to support such initiatives internally, given in-house subject matter expertise and quality management principles, using consultants can be a cost-effective option for developing a quality improvement program. EMS agencies with limited organizational knowledge of quality improvement should give serious thought to utilizing the services of a consultant. The consultant may come at a price, but that cost has been shown time and again to save the organization money in the long run. As denoted within the textbook, there are numerous consultants available who work specifically with EMS quality improvement. These include Fitch & Associates, Tridata, International City-County Management Association, National League of Cities, and Emergency Services Consulting International. There may also be local or regional consultants available to provide similar services. Just be sure, if contracting with a consultant for such services, to ensure the consultant is clear on the deliverables, benchmarks, and timeframes that must be produced or met. As a testament to providing high-quality care, some EMS agencies have obtained accreditation through the Commission on Accreditation of Ambulance Services, the Centers for Public Safety Excellence, or the Commission on Fire Accreditation International. To obtain accreditation, EMS agencies must have, amongst other things, a comprehensive quality improvement program in place that covers both clinical and dispatch operations. Returning to our scenario at the start of this module, how would an EMS agency begin to develop a quality improvement program? As mentioned in the textbook as a best practice, remember that while EMS is somewhat new to the quality management arena, this is not a new concept to business and industry. Reach out to local establishments that are recognized as having great customer service or that utilize quality programs and see what input they can provide to you. Given that you may be responding to their location to help a sick or injured employee, customer, or visitor to their property, they may be more than happy to provide you with some ideas as to how they have been successful in implementing their own quality improvement process. Many principles and ideas can be applied across different organizations, and it will invariably save your EMS agency time if it does not have to reinvent the proverbial wheel when there are others who can serve as resources by modeling positive behavior or sharing best practices. You can also survey your employees or members to see if any of them have a history or background in quality improvement projects. Especially if your service is volunteer, keep in mind that your members have other jobs at other organizations. Maybe they have some subject matter expertise in quality improvement that otherwise would have gone untapped within your agency. When you decide to move forward with your quality improvement initiatives, be sure to document your activities. Not only will that documentation provide valuable data to be evaluated as part of the PDSA cycle, accreditation organizations will want to see the fruits of your quality improvement labors. Documentation of this nature is difficult to reproduce, so begin the project with the end in mind and be sure to maintain good documentation throughout. As far as documentation is concerned, be sure to maintain reports on clinical performance, meeting minutes, and changes that were facilitated by the quality improvement process. As a cursory benefit, these documents can prove very helpful as your organization experiences turnover in key positions over time. Keeping an accurate history of your quality improvement activities helps with succession planning and can prevent others from making similar mistakes down the road out of ignorance and a lack of historical perspective and institutional knowledge. In closing, the history of quality improvement is rooted in scientific management and was influenced by experts such as Deming, Juran, and Crosby. While these individuals probably knew nothing about EMS, their principles of quality management definitely apply. The root of any EMS quality improvement initiative, for instance, must be the PDCA or PDSA cycle. If an EMS agency needs help in beginning or expanding a quality improvement program, there are numerous resources available through associations, accrediting agencies, and consulting services. At this point, many of the concepts discussed may still seem very abstract. Don't worry though, this module was only an introduction to the history of quality in EMS. Subsequent modules will delve deeper into these principles to facilitate greater understanding of what they are and how they are employed to manage a quality improvement system within an EMS agency.